Hi, my name is Dr. Lena Winestone. I'm a pediatric oncologist and specialist in transplant. That's my clinical focus. My research focus is actually on disparities in pediatric cancer, and I'm here to talk to you at the ASH meeting today about disparities in socioeconomic status as they relate to clinical trial enrollment amongst patients with pediatric ALL. And so to start, I think we need to start with the definition of what socioeconomic status is. We think of socioeconomic status as a combination of patients' and families' social and economic position. It includes things like income, it includes things like parental education, it can include occupation, family size, a variety of different factors. And so all of those factors come together to impact our patients' ability to participate in clinical trials. And as we think through this question, we have to start with where we get the data from. And unfortunately, in the setting of clinical trials, we often don't have detailed information about a patient's socioeconomic status. So while we collect very detailed information about, for example, their disease biology, the cytogenetics and mutational profile of their leukemia, we often have very limited data about a family's social situation, even though we know it has impacts on patient outcomes and potentially on their participation in clinical trials. And so because of that, we often fall back on proxies for individual socioeconomic status, and those things include a family's insurance, because we know that, for example, Medicaid insurance is means tested and therefore depends on a patient and family's income. And then we also use things like area-based measures of socioeconomic status, and that basically takes into account the environment in which patients live. Do they live in a high-poverty neighborhood? Do they live in a neighborhood with high levels of unemployment or high levels of vacant lots? And so those things we can use sometimes to get a sense of the environment in which patients exist, but it's still challenging to really understand the relationship between socioeconomic factors and clinical trial enrollment. I just want to delve a little bit into the data that does exist. We've been trying to look at this question for many years, decades really, and often what we've done is looked at the prevalence of pediatric cancer or pediatric leukemia in this case, and then the rates of enrollment by various sociodemographics. Most often we use race also as a proxy, and I'll just take a moment to pause and really think about the relationship between socioeconomic and race. And we think of socioeconomic status and race as really intertwined, and that's because of the existing structural racism that exists in our country. And so I just want to acknowledge that when we're talking about socioeconomic status, it's really difficult to disentangle that completely from race and ethnicity. So the historic data mostly has looked at things like racial and ethnic disparities. And in general, when we use that approach I described of looking at, for example, SEER data and then rates of enrollment on clinical trials, we see pretty comparable enrollment by race, ethnicity, and our best measures of socioeconomic status, which are typically at the area-based level. More recently, when we've tried to really drill down on it on a patient-to-patient level, we do find disparities exist. One of my colleagues, Dr. Aristizabal at UCSD, has actually looked at this in the population at their institution and has found that even among patients who do enroll who are Hispanic or speak a language other than English, primarily Spanish, there are issues with the way that they have understood the process of consenting. So we know that autonomy, for example, is a really key component of informed consent, and a lot of patients don't understand the voluntary nature of participation in a clinical trial, even among those that do enroll. And she's also demonstrated that the Hispanic population and those that speak have either low English proficiency or speak a language other than English are less likely to enroll. And further, she's demonstrated that health literacy is a key component in this, another measure that relates to education but is actually separate and independent. So your understanding of what a clinical trial is and your understanding of your child's condition really plays into how you choose to enroll in a clinical trial. I would say that the most recent and sort of comprehensive study we have is from Dr. Adam Green's group. They looked at SEER data and used that approach that I described, and they really didn't find any socioeconomic disparities when we're looking at the county level, which is the sort of finest level of geography that they have. But I think that the sort of downside to that approach is that we're really not measuring an individual's socioeconomic status, and that's why it makes it difficult. When we think about other factors besides health literacy that might influence, we think about the barriers that clinical trials in and of themselves put on families, because very frequently some of the requirements for clinical trials require them to come very frequently, require them to have additional lab studies drawn, and sometimes even the eligibility criteria can exclude certain populations. So there's a big effort within ASH to think about Duffy-Null-associated neutrophil counts, and that's something that we used to call benign ethnic neutropenia and have moved away from because it's not really a problem. We know that patients who have lower neutrophil counts because of their Duffy-Null status actually have equal protection from the neutrophils that they do have in their body. And so because of that, when we have requirements for a neutrophil count, it can systematically exclude certain populations. And the reason it's really important to have populations that are diverse, that participate in our clinical trials, is because it impacts the generalizability of our results. And so when we have certain groups that don't enroll, we can't generalize the results of those clinical trials to those populations. And that's one of the reasons that really it's important to both examine socioeconomic disparities and to try and mitigate them. And the last abstract that I'll talk about is a poster that I've put together with the Children's Oncology Group in my role as the Vice Chair for Diversity and Health Disparities in COG. And we looked at basically multiple ALL trials over the last 10 or so years and looked at that in relation to participation on registry studies. So I want to start by saying that this is a selected group already of patients who have agreed to participate in a registry and are being seen at a Children's Oncology Group site. So both of those already select a certain population. But when we looked at, again, area-based measures of socioeconomic status, we don't see any difference. We did find that there was a difference by distance to care, but actually when we looked at that in greater detail and really mapped it out, that difference was really being driven by patients who were being treated at St. Jude and were enrolling on a St. Jude trial potentially instead of a Children's Oncology Group trial. And so unlike in adult oncology where we know distance and rurality are major determinants of participation in clinical trials, we have not seen that effect nearly as much within pediatric oncology.